My next talk is Fetal Cardiac Diagnosis Made Easy, the Golden Rules. The talk is divided into an introduction and guidelines, which I essentially cover the issue of guidelines and compartmentalize cardiac anomalies. And then I go to the Golden Rules, which are simple practical tips to aid in cardiac imaging and diagnosis. And then I go through section by section showing anomalies in these individual sections that you may pick. So it's quite a compact, fact-packed lecture. You may need to go back and slow it down and listen to it, but I will cover a lot of ground going through all these sections and all the sentinel, about 45 cardiac anomalies. And then I'll finish up with some summary, some comments, and some take-home messages. So I like to compartmentalize cardiac anomalies into the major groups: left heart, override anomalies, septal defects, spatial range anomalies, and venous anomalies. Then there's the rare group and the heterotaxy, which are a mixture of these, and then soft markers and borderline cardiac findings. So essentially in this 1, 2, 3, 4, 5, 6 groups is what I'll be focusing on in cardiac anomaly detection. And it's important to have in your mind these groups. And the idea is, with the ISRO guidelines, that you go through in an axial section these 5 sections in trying to identify these anomalies. When you look at these 5 sections, it's important to have some idea of what you should expect to see in each of the 5 sections. So for example, in the 5 chamber, you expect to pick up tetralogy fallow, double out right ventricle, and common arterial trunk. You may also pick up narrowing of the aorta or post-stenotic dilatation for coarc and critical aortic stenosis, and also maybe TGA, where the pulmonary artery coming out of the left ventricle bifurcates. So it's important to know that these are the expectations on a 5-chamber view. And I probably should add to that a perimembranous ventricular or outlet ventricular septal defect. Whereas looking at the abdomen, persistent right umbilical vein, absent ductus venosus, umbilical vein varix, and importantly, the heterotaxies, seeing that the stomach and the heart are on the left side, but also the position of the aorta and the IVC. The aorta should be to the left of the spine, and the IVC should be anterior to the right. And any rearrangement of this should lead you to suspect, simply by looking at the abdominal section, that you're dealing with an abnormality or potential abnormality. So to help us go through this, these are just practical tips in cardiac imaging I just want to run through quickly. This is the descending aorta in a 4-chamber view, which lies to the left of the spine. And the chamber closest to that is almost always the left atrium. And that's an important anchoring landmark, because straight away, if I know that's the descending aorta, left atrium, that's automatically the sonographic right ventricle. And I need to prove that that is a morphological right ventricle by seeing a moderator band. So, 2, the vessel that's closest to the trachea is almost always, greater than 99% of the time, it is the transverse aortic arch. Number 3, when you look at color Doppler flow, always have red up and blue down on your scale on the left for the color Doppler when the apex is pointing upwards. So inflow is always red and outflow is always blue. You will invert the color settings if you have to invert the image. So when you look at this color setting, for every scan you do, you will automatically observe that a blue jet arising from the right side will be tricuspid valve regurgitation. Or if you see red along this vessel, you know that this is the trachea, the transverse arch, this is reversal of flow along the arterial duct. Or if you see this, the vessel close to the trachea is the transverse aortic arch, and this is the isthmus. This is an obstructed left heart lesion. So if you look at this sonographically, I can say, without knowing where the 4-chamber view of heart is, that this is the trachea, transverse aortic arch, this is an obstructed left heart lesion, and this is forward flow in the arterial duct. When I look at this image here, this is the trachea. There's forward flow in the aorta, but reversal of flow along the arterial duct. So without even knowing the 4-chamber view, on a 3-vessel tracheal view, I can have an idea whether there's an obstructed left or an obstructed right cardiac lesion. It's a very useful clue. Golden rule number 4 is the use of cine loop. So when I look at this 4-chamber view of heart, I see that the left atrium is smaller than the right and the left ventricle is smaller than the right. And I see there's a restrictive foramen ovale. When I look on color Doppler examination, you may not appreciate that there's bidirectional flow across the pulmonary veins. So what do you need to do? You need to slow it down. And now you can appreciate that there's forward and reverse flow in this fetus with the restrictive foramen ovale. And when you go to pulse Doppler, you can see this reversal of flow, equal velocity. But it's only by cine loop that I actually appreciated that bidirectional flow. Similarly, in a first trimester heart, you can see a common venous channel, all 4 veins, but there's bidirectional flow in a fetus with a restrictive foramen ovale and a hypoplastic left heart. So one in the first trimester and here one in the third trimester. So important is the use of cine loop in cardiac imaging. Golden rule number 5. When I'm scanning, I like to have a 2D image on the left and a 2D with color on the right. This allows me to see precisely the point of the regurgitant jet where it originates at the point here when the valves close during ventricular systole. It does not arise deep inside the right ventricle, and therefore it's unlikely to be an Epstein's, but rather tricuspid valve dysplasia or severe physiological regurgitation. So in a sense, split imaging is something we routinely do across all trimesters in cardiac imaging to precisely understand where the turbulent flow is arising from and where it is going to. You may also, when you look at a split image, not just color Doppler, is here with power Doppler. This also demonstrates the power of using balance. So when you turn the balance down, with a low balance, you're overwriting with 2D on top, and you're getting a nice demonstration of the pulmonary veins. Turning down the balance with using slow flow technology is really something you need to do in the second and the third trimester. Golden rule number 6. I'm going to ask you a simple question. Is this a normal 3-vessel view? Pulmonary artery, larger than the aorta, larger than the SVC. And it's sort of a trick question because I would not accept that as a right ventricular outflow tract view. Why? Because I don't have the right ventricle in view, I don't have the pulmonary artery in view, and I only have part of the information of the right ventricular outflow tract. I'm just seeing a little bit of the right pulmonary artery, I'm not seeing the left, and a little bit of the arterial duct. What's the point I'm making? The point I'm making, there are 5 components of the right ventricular outflow tract. There's the origin of the MPA from the right ventricle, the convexity to the left, the pulmonary valve, and then the other structures which I mentioned. And these are all listed here: MPA, RPA, duct, the left pulmonary artery. And diagrammatically, these are listed here. And you will all receive a copy of my handbook, which outlines these individual landmarks, and these images will be in the handbook. The important point about splitting an image when you're doing cardiac imaging is you understand the spatial relationship of the vessels to the chambers. So when you move from a 4-chamber view of heart up to the 3-vessel tracheal view, you appreciate the convexity of the right ventricular outflow tract is to the left. Very important to understand that because it's reversed in TGA, because it's the aorta coming out of the right ventricle. And that's why doing a split image allows you to achieve that. So this is the pulmonary artery with the normal curvature coming out of the right ventricle, whereas in TGA, it comes out with a reverse convexity to the right, comes out like this. So understand, by using split imaging of a 4-chamber and a right ventricular outflow tract, you will automatically recognize when the curvature of the vessel coming out of the right ventricle is reversed, TGA. Rule number 7. It's important to understand as the weeks of pregnancy go by, the velocities in the atria, ventricles, and chambers increase. There's a very useful rule of thumb: 100 centimeters a second. Now, for most of our cardiac imaging, it's in the first and second trimester and in the early third trimester. We do very little cardiac imaging around 36, 7, 8, 9, up to 40 weeks of gestation. If you use this older chart, there should be no pulse Doppler value of greater than 100 centimeters a second, whatever vessel you're looking at, up to 35, 36 weeks of gestation. If you look at more recent charting, by looking at MPA peak systolic velocities, in this case by way of example, if you look up to 35 weeks of gestation, you find that no point in time below this are the velocities more than 100. Wherever you sample, if you are suspicious of something and you find velocities more than 100 centimeters a second, it's likely that you're looking at a form of stenotic lesion across the AV valves or the semilunar valves. So it's a useful figure to have in your head without needing to refer to a chart. Rule number 8. When you are suspicious of a cardiac abnormality of the right ventricular outflow tract that's obstructive or the left ventricular outflow tract that's obstructive, it's very useful to compare one outflow tract to the other. And that's a reference point because the velocities are pretty similar across the aortic valve and the pulmonary valve. In this case, I'm getting velocities up to 120 centimeters a second. And I always ask myself the question, is that artifactual or is it real? There's no post-valvular dilatation. The caliber looks fine. The aortic valve doesn't look that thickened, but the velocity is raised. How can I be sure, though? I straight away jump from looking at the aorta in the same fetus. I then jump across and look at the pulmonary artery. You will also note there's a difference in the pulmonary artery. In the center of the spectral Doppler, it's hypoechoic. It's also a rapid rise to peak systolic velocity. In the center of this spectral Doppler, it's hyperechoic, and there's a slow lollipop-like rise to peak systolic velocity. So those three pieces of information are all included in golden rule number 8. It's important to be careful regarding the transducer that you use during cardiac imaging. I think it's a good idea when you're scanning to use at least 2 probes. Ideally, I use 3. I go at the frequencies above and below to find out what is going to give me the best imaging. I start off with this probe, a bilateral SVC. Vessel closest to the trachea is the transverse aortic arch, and this is the persistent left SVC because that has to be the pulmonary artery. There should be no vessel beside the pulmonary artery. What do? I go to a higher frequency transducer, so I'm moving all the way down in my frequencies to the highest here. And now I'm seeing a very nice image of a persistent left SVC here. And in fact, when I rotate on that vessel, I can see streaming down the persistent left SVC as it drains into the coronary sinus. I do not get that degree of detail when I use a lower frequency transducer. It's only going to a higher frequency. Remember, in cardiac imaging, try and get the best image by testing, are you using the highest frequency transducer and at the same time maintaining penetration? Golden rule number 10. It's a good idea in cardiac imaging to split the image so that you have the stomach and the heart demonstrated. And the reason for that is to avoid missing any situs abnormalities. As part of every cardiac examination, I look at the size, axis, rate, rhythm, and situs, and I demonstrate a single split image, and we do that routinely in the practice as part of a screening examination. Golden rule number 11. When looking for outflow tract VSTs, they are very challenging. And what I suggest you do is you get this view here, which is a short axis view showing the Mercedes-Benz sign, and recognize that you have the right ventricle, the tricuspid valve, and right atrium in view. And this will allow you to pick up these difficult views of the right ventricular, of the outlet VSDs. Let me show you what I mean. So you take a 4-chamber view of heart, you sweep to a right ventricular outflow tract, you got your pulmonary artery and the free wall of the right ventricle, then you rotate the transducer, and you rotate until you get to the ductal arch, and now, if you look at this image, at this point here, you have your Mercedes-Benz sign here, and this is your tricuspid valve and your pulmonary valve. This is the point which you want to catch just here. And it's here that you're going to be looking for your outlet VSDs. So when we look at this case here from a sweep from a left ventricular outflow tract, we are suspicious that there's an outlet VSD. The only way to prove that is by going into a short axis, tricuspid valve, pulmonary valve, RVOT, and here we have an outlet ventricular septal defect demonstrating this on color. So that's how you get it, how you get to that point. It's not easy. Golden rule number 12. Mitral valve regurgitation is rare. Tricuspid valve regurgitation is common. So be serious about seeing tricuspid valve, mitral valve regurgitation. This is the descending aorta, left atrium, therefore that's mitral regurg, tricuspid regurg. Another example here, mitral regurg. So anytime you see mitral regurg, just treat it seriously. It's likely to be pathological, unlike tricuspid, which is likely to be physiological. Golden rule number 13 is how to get an aberrant right subclavian artery. It's difficult when it's in this view. When you're looking at the internal thoracics, the left brachiocephalic vein, and the right and left subclavian artery, and the best view to have is in this angle. So you have the artery going straight out, both artery and vein, brachiocephalic vessel, and the internal thoracics coming in here. So that's the best angle to get when looking at it. So if you look here, we've got the 3-vessel tracheal view, the trachea, therefore that's the transverse arch, pulmonary artery, SVC, and here we have an aberrant subclavian artery going behind the trachea. You see the way I have it angled, so it's coming up towards the transducer. Also from a point of view of looking at a ventricular septal defect, I prefer to have the interventricular septum not lying transversely. I like it to have it at the apex of the heart pointing towards 1 o'clock or 11 o'clock, and then I can appreciate ventricular septal defects, particularly the tiny ones. Golden rule number 13. Slow flow has its greatest strength in the first trimester when compared to the second trimester. But in the second trimester, I made the point that if you turn on slow flow in the second, you can demonstrate tiny vessels that you cannot see with either power or color Doppler. And if you are getting a picture like this, consider turning down your balance if you're getting a lot of flash artifact. But this shows much more clearly than color Doppler or power Doppler. I can almost see it on 2D, but it's not showing up. As soon as I press one button, it becomes visible. Golden rule number 14, how to obtain a short axis. This is important, particularly with regard to AV canal defects, trying to distinguish between partial and complete. To achieve a short axis, you will not be able to do it with the apex of the heart pointing up at midnight. You will be able to obtain it by having the heart on its side with the apex at 3 o'clock or 9 o'clock, and then simply flipping the transducer 90 degrees. So this is a 4-chamber view of heart, and then you rotate your transducer. Now you have on top the tricuspid valve, and you can see the 3 leaflets, and the fish mouth opening and closing of a mitral valve inferiorly. This becomes important with a complete AV canal defect, that you can distinguish between complete and partial by getting that short axis view. But the only way to achieve that is with the apex on its side. Also, from the point of view of looking at the interventricular septum, the atrium primum and secundum, I think you can easily miss a partial AVSD examining the heart in this view. I think you need to have the apex up at 1 o'clock or midnight or 11 o'clock, and now you will appreciate this drop out here, and this is a complete AV canal defect. They can look so normal if you have the apex of the heart in a 3 o'clock, 9 o'clock position. Okay, so next what I'm going to do is to walk through the heart, having gone through all these rules, and go through section by section, starting off with the abdomen, 4-chamber, 5-chamber, 3-vessel, and the 3-vessel tracheal. I know it's a lot of information, so let's crack straight into it. So what are the abnormalities you'd expect to see examining the stomach? The aorta should be to the left of the spine, and the IVC should be anterior and to the right. But when you look at this sweep, you find the stomach and the heart are on different sides. The stomach is on the right side, and the heart is on the left. So straight away, you start considering the possibility of the atrial isomerisms, either left or right atrial isomerism or situs inversus. Particularly if the heart looks normal, you need to consider situs inversus. When you see the aorta and the IVC side by side, you need to be suspicious about this, because the IVC should be anterior and to the right. They should not be side by side. So seeing them either side by side or one on top of the other will lead you to suspect left or right atrial isomerism. It's important when you're looking at the intrahepatic vein that the gallbladder should be on the far side and the stomach here. But the gallbladder here is interposed between the intrahepatic vein and the stomach, and it curves towards the stomach. The intrahepatic vein should curve away. So these are the typical appearances of a persistent right umbilical vein. In this case, a transverse section through the abdomen, it's also important to see that the vein should curve away, but also make sure it does not continue posteriorly and connect with the IVC, the typical finding of an absent ductus venosus. You may simply appreciate it by looking at the stomach. Golden rule, continuing section number 1, it's in this view that you will pick up umbilical vein varices. We use a cutoff of more than 8 millimeters, and this is obviously more than 8, around 13 millimeters, with turbulent flow. They're not always extrahepatic. This is just after the point of cord insertion. Some of these are intrahepatic dilatation, and you can see this case here, more than 8 millimeters, with very obvious dilatation of the intrahepatic portion of the umbilical vein. And make sure it's not the gallbladder. Turn on color Doppler to assess this. Next section, the 4-chamber view of heart. In this case, descending aorta, therefore that's the right ventricle, hypoplastic right heart with a tiny amount of flow into the right cardiac ventricle. Typical appearance of pulmonary atresia with intact ventricular septum. In this case, 4-chamber view of heart, descending aorta, left cardiac ventricle. So this is a hypoplastic left heart. In this case here, descending aorta, left atrium, right atrium, poorly contractile, thickened right cardiac ventricle. And the heart is situated centrally within the chest. In this case, the axis of the heart is rotated, and you see this is the descending aorta pointing to an undersized left cardiac ventricle when compared to the right. So left axis deviation, hypoplastic, left heart. In this case here, when you look at the left ventricle is smaller when compared to the right. And when you look at this case here, the left ventricle is enlarged when compared to the right in the fetus with critical aortic stenosis. It's also got hyperechogenic myocardium, fibrinostosis. It's also non-contractile when you compare the contractility of this ventricle when compared to this ventricle. Next, we move on to this case of a four-chamber view of the heart, and we look at the size of the heart. The cardiothoracic ratio should be less than 50% according to the ISUA guidelines, and you can see, in fact, this is more subjectively. They had 60%, but you measure the circumference of the heart to the circumference of the chest. Next, you see in this case descending aorta, and therefore this is the right ventricle, which is grossly enlarged without pouching of the right cardiac ventricle in a fetus with a cardiac aneurysm. And then this case here, a very obvious abnormality with a large pericardial effusion, descending aorta, left atrium, left ventricle with a cardiac rhabdomyoma. Remember, once you see one, you then go looking for more. And this case here, in a four-chamber view of heart, you can see drop out into the interventricular septum with the apex pointing up towards 11 o'clock. But you can see with a high-frequency transducer using a linear 9, you can actually appreciate this muscular ventricular septal defect on 2D and without even applying color. In this case here, when you look at the four-chamber view of heart, descending aorta to the left atrium, you can see dropout in the region of the atrium primum. And when you look at this, you need to ascertain whether this is either a dilated coronary sinus, in which case the flow will be from left to right, or if the flow is from right to left in the setting of a atrial primum septum defect. In this case here, the 2D image is a split image, demonstrates a dilated coronary sinus here and flow going from left to right in a fetus with a persistent left superior vena cava. In this case here, you can gross enlargement, non-contractile heart, ballooning of the interventricular septum in a fetus with cytomegalovirus cardiomyopathy. And in this case here, a common finding in the third trimester in a four-chamber view of heart, descending aorta, right ventricle with tricuspid regurgitant jet, which is not reaching the roof of the atrium and heading across the foramen ovale. And in this case here, when you come across in a four-chamber view of heart, this is the stomach, and the heart situated centrally within the chest. When you look at this, it's got the morphology of a left cardiac ventricle. This is the morphology of a right cardiac ventricle, and there's a ventricular septal defect. So this is congenitally corrected transposition of the great arteries because you see the reverse boomerang of the vessel coming out of the right ventricle. And as you come here, you have the four-chamber view of heart, descending aorta, intracardiac echogenic foci, just at this point here. And you always need to consider the possibility whether these could be cardiac rhabdomyoma, and sometimes there's a crossover between the two. Four-chamber view of heart, descending aorta, so the right atrium is enlarged, rare to see these abnormalities, atrial aneurysms. Descending aorta, left atrium, right atrium with gross dilatation of the right atrium with a regurgitant jet rising deep from it within the right ventricle in a fetus with Epstein's anomaly. And lastly, looking behind the heart, you may pick up the common venous channel of total anomalous pulmonary venous return, which I mentioned earlier. You may pick up two vessels behind the left atrium in the setting of an interrupted IVC with azygous continuation. Sometimes you may see three vessels behind the heart with the interrupted IVC with azygous continuation, and the third vessel will actually be the esophagus. It will be transient and disappear with time. And then lastly, on a four-chamber view of heart with color Doppler, this is the descending aorta, and you can see multiple arterial pulmonary collaterals, and this is the view you look for them, seen in pulmonary atresia with intact ventricular septum. So that's the key abnormalities that you would pick up behind the heart. Now let's move to the five-chamber view of heart. Just shows the left ventricular outflow tract. And the key landmarks you're looking for here is the anterior wall of the aorta is continuous with the ventricular septum. You're looking at the continuity, the aortic valve to make sure it disappears completely. You're looking at the caliber of the ascending aorta, the curvature of the aorta, that it doesn't go up straight like an interrupted IVC. And you're looking to see there's laminar flow, no features to suggest aortic stenosis. So in this case, there's loss of that continuity in a fetus with a perimembranous ventricular septal defect. In this case, the aorta is sitting astride the ventricular septum. This could be tetralogy fallow, double outlet right ventricle, or common arterial trunk. In this case, you see the aorta is coming more out of the right ventricle when compared to the left. This could be a double outlet right ventricle with a subaortic VSD. And in this case, you're seeing a common vessel arising out of the center of the heart, branching into the pulmonary artery. This is a type 1 common arterial trunk. And this five-chamber, you see a thickened aortic valve with post-stenotic dilatation. Most of these are picked up on color Doppler, and most of them are picked up in the third trimester. On cross-section, you see that yin-yang flow of moderate to severe aortic stenosis, and the aorta appears slightly larger on that 3-vessel view when compared to the pulmonary artery. On a 5-chamber view, you see it's the pulmonary artery that's coming out of the left ventricle, and it splits, and that should never happen. And then here you have the aorta with that reverse curvature coming out of the right ventricle. And in this case here, you see that the aorta is the posterior malalignment of it here in a fetus with a interrupted IVC. You see that interruption here with this posterior shelf directed towards the left ventricle. In this case here in a 5-chamber, you see both vessels are rising out in parallel in the fetus with transposition of the great arteries. And in this 5-chamber view of the heart in the fetus with pulmonary atresia with intact ventricular septum, on this 5-chamber here, you see the coronary artery collaterals. So let's move to the right ventricular outflow tract. I mentioned about all the sections you need to look for. This is going from a 4-chamber sweeping up to the 3-vessel view, and it continues straight as the arterial duct. This one here, you see the branching right pulmonary artery behind the aorta and SVC. And this one here, as you sweep up from a 4-chamber, you see it branching into the right pulmonary artery going behind the aorta and SVC and the left pulmonary artery. So in this case here, you see a 3-vessel view looking at the right ventricle. You've got the free wall of the right ventricle, and you've got turbulent flow distal to the pulmonary valve stenosis, typical appearances. This is infundibular pulmonary stenosis, so you don't see the turbulent flow, but rather a reduction in the caliber of the pulmonary artery with a Y configuration in a fetus with tetralogy of Fallot. In this one here, you sweep from a 4-chamber view into a right ventricular outflow tract, and you see that the great arteries arise in parallel as you sweep. And in demonstrating in the same features on the right with stick volume. But you see the way they both come out of the right ventricle with no crossing over of the great arteries. And then you slow that down with the stick volume, both of these coming out of the right ventricle in parallel. When you sweep, in this case, from a 4-chamber to the right ventricular outflow tract, you see both arteries come out in parallel. And you can demonstrate this also on color Doppler in a fetus at 13 weeks of gestation with a double outlet right ventricle. I've mentioned over and over again the importance of splitting image, showing a 4-chamber view of heart and then updating it and showing that single vessel arising from the right ventricle with only 2 vessels on the 3-vessel tracheal view. But this vessel is coming out of the right ventricle and it's got reverse curvature. It should be going in this direction, but it's going in this direction. And we reported this as the boomerang sang. Both we reported in the 2nd trimester, first in the first paper and the second in the 1st trimester pregnancy. Lastly, the 3-vessel tracheal view. We look at the 3-vessel tracheal view as a very powerful view in looking for cardiac abnormalities. This is the trachea, the transverse aortic arch, pulmonary artery, the SVC to the right of the trachea, and there should be no vessel beside the arterial duct. When we look at this 3-vessel tracheal view, this is the trachea, and the vessel that's closest is the transverse aortic arch, and the caliber is smaller when compared to the pulmonary artery, a typical feature that we see with coarctation of the aorta. In this case here, we ask, is this a left or right heart obstruction? I've already covered this. I can tell you straight away that it is a right heart obstruction because this is the trachea, transverse aorta, and we see reversal of flow. It could be pulmonary atresia with intact ventricular septum, severe pulmonary stenosis, Epstein's anomaly, and so on. In this case, this is the trachea, SVC, and this is an obstructed left heart lesion. This could be a critical aortic stenosis, could be severe coarctation, could be hypoplastic left heart syndrome, could be mitral atresia with VSD. So straight away you can tell on looking at 3-vessel tracheal view color that you have left heart obstruction. It's also a perfect section for looking for a right aortic arch, and this is the trachea in the middle creating this vascular ring. And you can also see a double aortic arch, and this is a fetus in the 1st trimester with the splitting of the aorta around on this either side of the trachea with the arterial duct here. It's what's described as the Z configuration. You may also appreciate the more subtle varieties of double aortic arch where you can have an atretic segment, a non-dominant segment. So this is the larger right branch and a small atretic left branch, and this is the pulmonary artery and the arterial duct with an aberrant left subclavian artery commonly existing with a right aortic arch. I've already mentioned in this view you also see an aberrant subclavian artery, and this is a 1st trimester aberrant subclavian artery at 12 weeks and 5 days. This is at 20 weeks and 3 days. And remember, have it pointing up towards the transducer. In this case here, you see there are 4 vessels on the 3-vessel tracheal view, and this extra vessel is going in a reverse direction to the SVC, right SVC. And this is a ascending vein of a total anomalous pulmonary venous return. In this case here, you can see 4 vessels, and this sitting beside the pulmonary artery is a persistent left superior vena cava. This is showing here a 4-chamber view at 13 weeks, and then you sweep up, you see only 2 vessels with reverse curvature, TGA in the first trimester. Another case, which I'll talk about in my first trimester talk, showing transposed great arteries arising from the right ventricle. In this case, I ask you, is there any problem? This is the descending aorta, which you see here is not on the left, but the right side of the spine. And then as you sweep up to the 3-vessel tracheal view, you see you've got a right aortic arch and a right arterial duct. And you look at the pulse stop, you see that also pulmonary valve stenosis. So right aortic arch, right arterial duct, and pulmonary stenosis. Once you see one problem, you look for another. This is a case of a dilated left brachiocephalic vein, and if you ever see that, you need to suspect total anomalous pulmonary venous return of the supracardiac type, or severe growth restriction, or vein of Galen aneurysm that causes this dilatation. In this case here, when you look at the 3-vessel tracheal view, if you ever see a right aortic arch, you always ask yourself the question, is the thymus gland present? And if you see that the aorta sits very close to the sternum, this is a clue that you've got an absent thymus. So in summary, I've covered a lot of ground here, but I'm hoping that if you apply the 15 golden rules along with an understanding of the sentinel cardiac abnormalities and what you can see section by section, I think you will move a lot closer to improving your detection rate of cardiac abnormalities. Thank you very much for your attention.